Oh, oops. Okay. So I don't need this, right? I should be mic'd on this? Is that right? Well, thanks so much for that. Can you hear me? How's the volume? Yeah? Good? For that kind introduction. And again, I apologize for being late. The event last night was a dinner honoring two people who are getting honorary degrees from Hopkins today. Edie Windsor, a New Yorker, and her lawyer, Roberta Kaplan. And so that's one of those invites you have to say yes to, right? I mean, yeah. So what I want to talk with you about today, and some of this will indeed be work either from the Lancet series on MSM or some updates on it, and then some additional recent work that we've been doing, and I'm going to touch on 078. We're so happy that we have a number now. You know, it doesn't mean any resources, by the way. No, but once you have a number, you know, things are different. Hey, Alex, I didn't see you there. And I thought I would talk about the global burden because I think that that's really important for framing all of our discussions and thinking about this problem. Talk a bit about etiologies of risk because, again, I think that that really helps us think about what it is we really need to intervene on. A little bit about the continuum of care because I think this is, you know, people phrase it in many different ways and think about, for example, the cascade of care, the cascade of prevention, the continuum from testing all the way to full viral suppression. But again, that continuum for men who have sex with men in particular is something I think we really need to think about together and think about what are the critical pressure points that we are not addressing in our current approaches, right? Because that's unfortunately the reality we're in. And then hopefully talk about some new tools, new approaches, and new ways of addressing the epidemic. So a little bit about the global burden. This is indeed from the Lancet, and I'll show you, this is prevalence data, but I'll also show you some more recent updated incidence data that unfortunately underscores we're in the same place. But what you're looking at here is a global comparison by region of all the available data. This is a systematic review and meta-analysis with confidence intervals around these estimates. And you're looking at men who have sex with men, for example, here pooled for all the data available for sub-Saharan Africa, and then all men of reproductive age from the same region. And most of those are UNAIDS estimates from country prevalence. So what you see is, of course, the highest burden region in the world for all people is sub-Saharan Africa, about 5% of reproductive age adult men, higher, of course, in the Deep South. But even there, men who have sex with men, substantially more burdened. And that holds true even in quite low prevalence areas like East Asia, Western and Central Europe, Oceania, but it's particularly the case in sub-Saharan Africa and the Caribbean. We're in the thick right now of a major battle, two battles going on in Jamaica and in Belize around the sodomy laws in those countries. And these data have been, are in both countries being used and misused in a number of court cases right now. We actually just had a victory yesterday. The principal person who's been a recipient of PEPFAR and Global Fund money and has been arguing that sodomy laws are good because homosexuality is bad and is a risk for HIV infection, was just fired from being head of the Global Fund recipient in Jamaica, Brendan Bain. So you got to savor those victories. They don't happen so often. This is the same data, but looking globally, and I just, putting it on a map, want to point out that at least up through 2012, all these countries in lavender are places which still have not done an assessment of HIV among men who have sex with men. And this, of course, is coming into the fourth decade of AIDS, and we have known for hey, Theo, I didn't see you there, for a very long time, of course, that men who have sex with men were at elevated risk. You're all probably familiar with this, the most recent data from the CDC, but just to say that the United States looks, unfortunately, very similar. This big yellow slice is the proportion of new infections up through 2010 attributed to male-to-male sexual exposure. This is what it looks like in terms of trends. This, again, is from the CDC. And just to say, I don't have the confidence intervals here, but the injection drug use epidemic in the United States happily is in decline, the heterosexual epidemic in modest decline. The only part of our epidemic which is expanding is men who have sex with men. And if you see a trend going up in that direction, that actually is statistically significant for trend. So that is the one component of our epidemic that's expanding. And of course, this has marked health disparities. Elvin and others in the room have worked on those health disparities. This is the youngest age group, 13 to 24-year-olds, so really looking at the future of HIV in this country, and of course, in young African-American men and adolescents, hugely disproportionate burden. This is syphilis, again from the CDC, and just to say this is all reporting of syphilis cases in the US. Happily, the epidemic in women in the United States is somewhat in decline. Men who have sex with women also in decline. But syphilis is expanding, and it's expanding because it's expanding in men who have sex with men. Right? That is not good. And I would just point out that there's been some recent work on incident syphilis in men who have sex with men, and men who present with new onset diagnosis of syphilis and who don't have HIV infection are at incredible risk for HIV acquisition in the next 6 months. Right? So this is really a bellwether indicator for us about people who need intensive interventions and who, for example, might benefit from PrEP. I didn't say it. Bob said it. You heard that. Just to say that we also have an epidemic, unfortunately, of sexually transmitted hepatitis C virus in men who have sex with men. This is also a nice recent paper on this. And this is really predominantly in men who are also living with HIV infection. So there appears to be an increased susceptibility to acquisition, sexual acquisition of HIV among men who are co-infected with HIV. But of course, that is relatively rare in other populations, sexual transmission of HCV. I thought this was a very important piece to share with you. This is cohort data, so not cross-sectional, but rather prospective data from the Bangkok cohort. This is work by Fritz van Griesenven and his colleagues at the CDC and also the Thai Ministry of Public Health. And what you see overall here, these are men who are enrolled, seronegative, and followed for 5 years. So it's a 60-month, 5-year time frame. Overall, about 24% of these men became infected with HIV over the 5 years of being in this cohort. Now, this is with regular HIV testing and counseling, condom distribution, water-based lubricants, treatment for sexually transmitted infections, individualized risk reduction counseling, and in a country with universal access to ARVs. Right? So that's the background. Right? And by the way, true or false, Thailand has never had laws criminalizing same-sex behavior.
True.
True. Yeah. Never a colony, only country in Southeast Asia not to be a European colony, doesn't have that European legal legacy. Nevertheless, that's what you see. And I would highlight this curve in blue. That's the 18 to 21-year-olds. So that's the youngest age strata. Again, all of the basics of prevention, access to counseling, treatment, care, condoms, etc. 31% of them became infected over 5 years. That is about as transmissible as HIV gets. Right? So we are seriously failing with the current prevention efforts in a well-studied population. So I think we all have to ask ourselves, why is that? And I'm sure that many of you have ideas, and there's lots of theories, and there's lots of papers. We tried, again for this Lancet series, basically to pull all of the available risk factor data, pull it together, and try and answer this question, why do we think this is happening in this late phase of the epidemic? So the first thing to say is that when you look at individual risks, they are not predicting well these behaviors at all. And I will show you some data from African American MSM that really underscores why thinking about individual level risk behavior in this kind of epidemic context is just insufficient. It's necessary, but it's insufficient. It turns out that network level risks are really critically important. And that, for example, that Bangkok data illustrates something very profound about the way HIV is moving through networks, particularly of young men who have sex with men. And there are a couple of factors that really matter. One, of course, is the sexual versatility in MSM networks, which is very different from heterosexual networks. Everybody knows what I mean by that?
Yes.
I know you know. And then, of course, there are other features of these networks that are different, right? Lower density, much larger networks. There's a number of papers that have shown this from the US, the UK, China, Australia, and other places. And then, of course, in much of the world, and I don't have to tell this audience, we are still dealing with a huge set of structural barriers that include HIV criminalization of same-sex behavior, stigma, discrimination in healthcare settings. I'll show you a little bit of data, some qualitative data that we're about to publish on that. And of course, a range of other structural barriers, even where we don't have criminalization, that really matter, for example, with minority men who have sex with men in the US. One other feature of this that I think is just critically important, and when we talk about prevention, we really have to keep this in mind, is that while we're talking about networks and men who have sex with men and behavior, we're also talking about the biology of HIV transmission. Now, this is a gut-tropic virus that is efficiently transmitted through anal sex, irregardless of the gender of the receptive partner, right? It's not a gender issue, it's not a male issue, it's really a colon issue. So this is the meta-analysis, the best available data, recently updated by Bagley et al., that is looking, a lot of this is from European cohort study, at the transmission probability in receptive anal intercourse. And just to say that the summary estimate here is 1.4 per 100 acts, which is an extraordinarily high level compared to heterosexual, to vaginal penile intercourse. It's 18 times the transmission probability per act of vaginal intercourse, which is a huge difference in efficiency of transmission. And that explains a great deal of why condom use has to reach really extraordinary levels to be effective, right? With 18 times the probability and with very high burdens of infection, you don't need a lot of risk, in fact, very modest risk, to generate a very high lifetime probability of HIV acquisition. Right?
Could you say something about the heterosexual group?
Yeah, so this is a European couples study of couples who report anal intercourse. And of course, as you doubtless are aware, when men and women practice this behavior, only the female partner can be the receptive partner, right? So that also is, of course, a difference in MSM, epidemics, networks, dyads, relationships. Yeah?
This has to be taken into account the prevalence of HIV in that specific population.
So transmission, these are samples, mostly from discordant couples. So these are not estimates based on prevalence from populations. They're estimates of transmission probability from cohorts.
So in reality, it's even worse because prevalence of HIV among MSM is much higher than.
Yeah. The per partner transmission probability, if you look within discordant couples, is again dramatically higher. And for men who have sex with men, it comes out to about 40% per year. So, in 2 years or 3 years, that of course is for couples who are reporting unprotected sex. Now, much of this data, if you look at the years that it's published, some of it, like the DiGrutola estimate, is pre-heart, right? And all of these estimates, happily, would be affected by now treatment in the infected partner. But nevertheless, the transmission probability is important. And the unfortunate reality is, particularly with young people and young men who have sex with men, there's a substantial proportion of them who are infected, don't know it, and are, in this high transmission probability category. And just to point out that in this meta-analysis, there's no difference by gender, right? So this is to say, even though this is a biological reality for men who have sex with men or for anybody who practices receptive anal intercourse, this is, again, not about being gay or homosexuality or any of those issues. It's about being the receptive partner in anal sex. People look a little sad about that. You all right? Is everybody with me? All right. So these are all realities that are out there, but of course there are many other very powerful barriers, some of which have been measured, some of which have been attempted to be intervened on. We've been doing work in southwestern Tanzania for a project That now has actually morphed primarily into a sex worker study, but at the time, we were also looking and exploring what life was like for a rural population of men who have sex with men. And these are qualitative reports from that study in Iringa. So this is from a 27-year-old man. If it is known that you have sex with men, you can be scorned. Why do you do this stuff? A grown man who is penetrated. Instead of getting the things you need, you have to just leave. And what he was referring to is you have to leave the clinic. Right? If you go to health services like this, even the nurses, if the doctor knows you are a certain type, he won't give you the treatment you deserve. Right? Let's say you have an infected anus or a disease, HIV, gonorrhea. It's stigma. They ask, how did you get this? Why? So you tell them, I like men. Even doctors are drawing the line where gay people or female sex workers are concerned. They find it disgusting. So these are the kind of things where people actually get to the point where they're ready to disclose risk behavior and seek care, that they're getting excluded from care. A lot of this fits into what Ron Stahl and others have called the syndemic hypothesis, and this is basically the idea that particularly LGBT adolescents grow up in climates of lack of acceptance, face many losses for disclosure of sexuality, friends, family, religious abandonment, and all of these come together in issues that you all in the Psychiatric Institute know a lot more about than I do, depression, substance use, internalized homophobia, and HIV risks. In my view, these really are important. They're certainly important for a subset of kids who have trouble coping. They probably do explain a substantial amount of HIV infection, but of course lots of kids grow up and do just great and still have very high risks of acquisition. So we have to start looking at other reasons why people might be doing so badly. And I think if we think about African American men in the US, they really help illustrate the challenges we're facing. This is a very nice meta-analysis, 174 studies in the US, comparing black versus other men who have sex with men. Greg Millett, who did this work when he was at the White House, now just joined AMFAR in DC, which we're all very excited about. But this is his work and that of his colleagues. And just to say, what you're looking at here, this is the line of union. Everything on this side means that African American men are more likely to report or to experience these behaviors, and anything that doesn't cross that line is statistically significant. On this side, these are less likely for African American men, more likely for African American men. And at the very, very top, what would that be? I know it's hard to read, but what that is other black partners. So that is the network effect, right? The people that you're having sex with, particularly in a very high prevalence, high incidence dynamic, have a huge impact on whether or not you have HIV. But then there are a bunch of other things, like having an STD, not being treated, starting at a lower CD4, less likely to be virally suppressed. That's probably a critical parameter. Less access to antiviral therapy, fewer clinic visits. Those sound like individual level risk behaviors and sexual risk taking, right? They're almost all structural. And then you get onto this side. What's more common in white men? Well, for example, number of sex partners. Significantly higher for white men than black. Same race partners going in that direction. Serosorting more common in white men. Drug use before and during sex, right? A typical thing that you would think, well, that's going to be different and that's going to be a risk. Doesn't explain these differences at all. Methamphetamine use, of course, substantially less common in black men than in white, poppers, and so forth. So when you put that all together, and this is the cascade that has been derived from those data, basically African American men much more likely to have undiagnosed HIV infection. If they are tested, more likely, of course, to be positive, less likely to have health insurance, ART utilization, to present later, to be adherent, and finally, all the way at the end, to have successful viral suppression. And when we think about this cascade now, I think this is really where people are, that being linked to care or being started on care is not a terribly useful parameter. The parameter that really matters is successfully and sustainedly virally suppressed. That really is the goal, and that's the critical prevention goal. And this is summarizing all of those, the strongest pooled factors: lower income, poverty, of course, an overarching issue, lack of health insurance coverage, and a substantially lower number of healthcare visits. So all of those are structural issues relating to healthcare. Right? Now this is data we presented at CROI, hasn't been published yet. We're working on that, should be out fairly soon. But this is from an NIMH-funded R01 that we have been doing. It's the second R01 that we've had with our colleagues in Moscow, Russia. And I'll just tell you, when I'm done with these data, where we are with this. It's a little bit of a distressing story. But just to say, we did a large sample of about 1,600 men. We were interested in providing safe testing in an LGBT-positive environment. And the clinic we were working in is the only one in a city of 12 million people that had a waiver to do truly anonymous VCT. So you could come in, you could get a test, you could bring your partner in, and you would not have to do name-based reporting. Because in the Russian system, the Russian Federation, all HIV testing is name-based, and you can't access ARVs unless you go through the government system, unless you're rich and you do it through the private system. But for the public system, you have to go through this.
With enormous stigma.
Yes, yes. And by the way, still very old-fashioned categories where you then become an officially registered homosexual with the Putin administration. How many people are volunteering for that, right? That would be no one. So nobody wants to go near that system. So about 1,600 men, a very high proportion had ever been tested, and that is because testing is ubiquitous in this country. People get tested for insurance, they get tested for jobs, they get tested for university. Whether or not they get counseled or they ever get the results, or the results have any validity, is another question. But nevertheless, testing is extremely common. And then when we get down to, did you ever disclose, for example, the fact that you're a gay man or a man who has sex with men to a provider, very, very low numbers. This is the analysis for just the men who we identified with anonymous VCT and then with confirmatory testing that we actually believe was quality HIV testing. A little over 200, about 15% of the sample, were living with HIV, and 20% of them knew that they had HIV infection. That is an extraordinarily huge proportion of men, 80% or so, with previously undiagnosed HIV. And of course, undiagnosed HIV is untreated HIV. This is in a country, right, that is rich, relatively speaking, powerful, has had supposedly universal access for many, many years. And then you can see the trail off when we finally get to actually successfully treated. It's 9% of positives, and that would be well under 1% of the total population. So it should surprise no one that this is an epidemic out of control. What happened with this study was that last fall, we started to hear word from the clients, from guys using the study, that they no longer felt safe. A typical Russian thing is that you don't necessarily see the police. There's nobody who shows up, nobody in uniform, but rather kind of thuggish types appearing, hanging around, threatening people, never really know who they are, and people started to vote with their feet and feel like the clinic was under surveillance. Shortly after that, the staff, who are mostly nice, straight Russian ladies, and everybody, they're all women, heavily physicians, women, they started to say, we don't feel safe coming to work. So at that point, of course, we had to go to our IRB, we had kind of an emergency meeting, and we decided that we would suspend the service, and it now has basically been shut down. So that was the only place in this city for anybody, not just gay men, but for anybody to get a truly anonymous HIV test. So, tough moment, very tough moment. Just to say, you know, there are lots of groups out there. Of course, many of the people in this room are involved, partners, collaborators, working on new ways of addressing this. And I think this schematic from Patrick Sullivan's prevention paper in Lancet is enormously helpful for thinking about what is next and what we have to do. So what you have is a couple of the critical factors, like the high biological risk of anal sex that we talked about, the high viral load in partners, and that's a large proportion of men who are untreated. Great example would be Russia. High STI incidence, including syphilis, of course, and lack of HIV serostatus, the awareness of serostatus. So what are the things that we have? In the biomedical area, we have condoms, we have PEP, and we have PrEP, all of which can help address this issue, right? And then none of those are going to work without behavioral components, as we know. So we got to increase condom use. PrEP adherence is pretty much everything in PrEP, as it turns out, but also alcohol and substance use impact adherence, and of course, as we've known for many years, impact condom use. So important role there. And then there are these structural enablers, right? CCHC is clinically competent healthcare. Again, unfortunately, an example I shared with you from Tanzania and from Russia, this is an enormously challenging component. High viral load, of course, there is treatment. And until very recently, we had no empirical data to suggest that treatment as prevention worked as well for male-to-male sex as we did for the heterosexual study HPTN 052. But that's changed with the partners data, which I'll show you a little bit of that in a moment. The behavioral interventions there, and this is what Bob and I are working on, is linkage to care. ART adherence, of course, retention in care, because what we really care about is viral suppression, HIV testing, and again, obviously, healthcare, stable supply chains, lab capacity for monitoring. High STI incidence, I won't go through all of this in detail, but just to say that I think what emerges from this paradigm is we need combination interventions with the new biological tools linked to behavioral interventions, really working in consort, and that address what we think really are the critical risks here, right? And we are not talking about, for example, reducing the number of sex partners, which is an incredibly difficult thing, even if you think it's the right thing to do. The data suggests it's not that important, right? White men have many more partners than black men. Black men have 5 times the prevalence. So that's not an intervention target that we think is going to really make a difference. And we're not, of course, talking about other things like abstinence. Not really an option. We are talking about much more frequent testing. When you look at that list of interventions, most of them now, and all the new biological interventions, are status dependent. So testing is the gateway into these. You need to know if you're positive, get into treatment. If you're negative, think about your other prevention options. This is just a great example, a Thai, very aggressive campaign, Adam's Love. This is a famous straight actor, but he's kind of the poster boy for this, encouraging young guys to get tested. APCOM, the community group, has a similar one. It's kind of X-rated. I didn't want to show it. Everybody an adult here? Their new it's true. Yes, I can say it. Everybody, their campaign is called Suck, Fuck, Test, Repeat. Isn't that nice? And the graphics are great. You can Google it. Please, feel free. Now, PrEP. Of course, we're in a world of controversy around PrEP, as everybody knows. I don't actually understand a lot of that controversy. It seems to me that in many ways, this is an option. It's not so different from contraceptive choice for women. There's lots of different choices for women, and we don't say that a woman who chooses pills over an IUD is somehow morally, suspect. Nevertheless, these are the data from Bob Grant's original trial, showing that very nice, clear separation, much higher acquisition risks in people on placebo than people on drug, sustained over time. That's just what you want to see. And just to say that this, for those of you who haven't seen this is a post hoc analysis of the IPREX data. So, of course, caveats to the post hoc analysis. But what you're looking at here is the measures of the active intracellular component, which is tenofovir diphosphate. And what he's done, essentially, is look at what the drug levels correspond to and what the incidence looks like in the population. So this is men who were consistent with drug levels of about twice a week, and you can see really an impressive reduction already. But when you get out to 4 dosings a week, or the folks who had blood levels consistent with daily dosing, we're nowhere near the kind of 40% in the trial. We're really looking more in the high 90s. So this is an extraordinarily effective intervention if people want it and take it and use it. And we keep talking about 40 or 41% efficacy. That is the intent to treat analysis in the trial. The actual efficacy, if used as prescribed, is much closer to, this is actually comes out to, for daily dosing, at about 96 or 97% efficacy. And that is really remarkable because, remember, we're talking about that high transmission probability in anal sex. And it's important to keep in mind, happily, this is oral dosing, right? And tenofovir diphosphate, where it's turning up, is in the epithelial cells of the gut lining, right? So this is an oral drug for a rectal transmission issue. Let's think about that, because that's not the way people perceive it currently.
Do you know much, just a minor point about vaginal infection?
Well, so, the vaginal compartment is different, yeah. And so vaginal epithelial penetration of oral agents is a challenge. And so, there's a lot of questions about the comparability of the compartments, how we understand the measures, and of course a lot of interest in intravaginal products, particularly those that might work locally and have less systemic absorption. You deal with less of the drug resistance issues. The dapivirine ring is now kind of the next study that's up. But for a rectal STI, which is what HIV is in gay men, an oral dosing is probably not a bad idea. So these are the data that were presented at CROI. This is Jens Lundgren's European study. And this is really very heartening because it's a large number of couples, but almost 300, 280 or so of these couples were male same-sex couples, right? So these are people who are being followed prospectively over time. One, either the man or the woman in the heterosexual partnership or one of the two men is living with HIV. And these couples only had to report some unprotected anal intercourse, and they had to not be on PrEP. PrEP was offered, but if people wanted PrEP, they're not in this analysis. So none of these uninfected partners are on PEP or PrEP, but the infected partners are all treated. Right? Everybody's treated here. This is a treatment cohort. And for the most part, I don't have the treatment data here, but they had sustained viral suppression. They're well-treated populations. So what you're looking at here is the transmissions across these couples, right, with vaginal intercourse, men who have sex with men, the male couples, receptive anal sex with ejaculation, receptive anal sex without ejaculation, insertive anal sex. And what these have in common is that the transmissions across all of those groups were 0, right? That is 0. Okay, champagne, right? That is the first empirical data that we have that has looked at a sufficient number of male same-sex couples to answer the question, does treatment prevent transmission? Even in couples who are practicing that term we don't love, that Alex has published a lot on, bareback sex, right? They are having unprotected anal sex with ejaculation, and there still were no transmissions picked up. So that is really encouraging. Now, this is couples, right? Those of you who know gay men know that couples have a lot of different meanings. They're constituted differently, right? Sometimes what you mean by a couple is people who live together and walk the dog and haven't had sex in years, right? I mean, or couples are, commitment to only have third partners together, right? I mean, there are a lot of different ways that men construct sexual behavior in couples. And what that means is the actual population level impact of this and the way that it might work in those networks is unclear. Happily, we're going to answer it in HPTN 078, right? And so this is our new study. I won't go into all of these except to say that there is lots of work on this area, happily. But what we're attempting to do is to look at the treatment side of prevention and do enhanced recruitment, linkage, retention, viral suppression to see if we can, I'm sorry this isn't showing up, reduce incidence at community levels through enhanced treatment. And the design, if we ever get to the design of the efficacy trial, is a community randomized design, because you really can't do this answering questions within couples. You need to do it at a community level. And of course, lots and lots of particularly young men are not necessarily coupled. And they also obviously play critically important roles. And that's why we decided that a discordant couples design was not going to work to answer this question. I'm not going to go into this in great detail because we started late and we're running out of time a little bit, but just to say we have been working with Ron Brookmeyer at UCLA, who's a wonderful statistician, Patrick Sullivan at Emory, Linda Gale Becker in Cape Town, on an MP3 award with men who have sex with men in South Africa, trying to look at what combinations of these packages might be the most effective. We actually have just run the numbers. This is coming out shortly in Statistics in Medicine. But I will just share with you, this is overall what it looks like. It's an agent-based stochastic model. that if you just provide treatment, and this is in a South African population of men who have sex with men, you really get a very modest bump in prevention. This, again, is modeling data. About 10% of new infections over 5 years can be reduced with enhancing treatment uptake and use. If you add PrEP for high-risk individuals and have 50% of them accept, you get up sort of better, but it's only around 12 or 13% of new infections. If you can also reduce by 15% unprotected anal intercourse, you get an enormous increase in the impact of antivirals, right? And why did we choose 15%? Well, everybody knows about Tom Coates' big behavioral intervention trial, right? Project, what was it called again? Accept, yes. So that, no, not Accept, the MSM trial, Explore. That was about the outcome that Explore was able to measure. It was able to achieve a 15% reduction in that cohort. And if you add that with PrEP, now you're starting to get up to about a third of new infections over 5 years. So that combination is treatment, PrEP, and behavioral interventions. And just to say that happily we found one synergistic, potent effect, which is the impact of testing. Testing turns out to be quite synergistic with PrEP and with treatment. So if you add enhanced testing uptake, and those are the dotted lines, you now get up around 35% of new infections over 5 years, and that may be enough to start to bend this curve. So stay tuned. That, I think, is perhaps the next generation of prevention trials is going to have to do treatment for positives, PrEP for negatives, and behavioral interventions for everybody. Just to say, this is going to take money. This is an analysis we did with AMFAR of funding for MSM programs in a number of countries. India before and after decriminalization, pretty dramatic there, less than 1% of funding up to about a third. That, of course, has started to go down. But lots of countries have still never spent a penny on this aspect of the epidemic, and we still obviously have a long way to go to get there. So, the basics, I think this is how I would summarize it. The basics of prevention are not enough. We have a serious epidemic that is out of control both in the US and in developing countries in men who have sex with men, particularly in the youngest strata. We're going to need better epi. We need these new prevention tools. We really need to figure out how to optimize care and reduce that viral load at population levels. We have to adapt treatment as prevention to MSM, so that is Bob's job. We're going to need combination approaches, right? I think that the evidence for that is really abundantly clear. All of them are going to require better adherence and regular adherence to testing. So, for the highest risk strata of men, every 6 months even may not be enough. Some people are thinking that every 3 months is better. Structural interventions are going to matter in lots of places, and that is going to be a long, slow, difficult road. And if you thought structural interventions were hard, social and cultural change, also not easy, but then again, we just had dinner with Edie Windsor, and, there is change happening, at least in some places. George Comstock, who was a mentor of mine and a great professor, epidemiologist in TB, used to say at Hopkins all the time that TB anywhere is TB everywhere, and that if you don't control TB transmission cases, the epidemic will recur. In my view, that is exactly the analogy that we're facing with HIV. HIV anywhere is HIV everywhere, and this epidemic in MSM right now is the expanding part of global HIV, and it is not in control. So this rhetoric that you hear about the end of AIDS and controlling AIDS, and it's coming to an end, and we're winning and victory, yeah, but not yet. This is a beautiful quote from Tony Fauci that I just wanted to end with, because I'm in New York and I was a medical student here, but also buried a partner here and lived through that tough period, as many did. Clinical development of heart, and Mark Harrington is also a co-author on this. This was for our Lancet series. Relied on the contributions of thousands of men who participated in clinical trials that provided the initial proof of concept and subsequent refinement of heart as life-saving therapy. The significance of the contributions of these men is profound. We really couldn't be having this conversation if people hadn't participated in all those trials and we didn't have heart. And I know many of you were providers and community members and part of that effort, and we're all deeply in each other's debt. This is my colleagues and people who worked on various aspects of all of these studies. Just to say the funding is from AMFAR and the Gates Foundation, the Hopkins Center for AIDS Research, which is NIAID funded, and the Sibanye project is a NIAID R01. Thanks for your attention.